Welcome back. Let's dive straight into today's explainer on the clinical matrix of spinal cord pathologies. Look, if you're aiming for that 270 plus score, you know rote memorization just isn't going to cut it anymore, right? You absolutely need diagnostic precision. So we're going to isolate the structural rules, break down those really intricate mechanisms, and highlight the exact clinical traps you're going to face on test day. Let's just get right to work. Let's immediately analyze the cervical spondylologic matrix by strictly contrasting two totally different pathological processes. On one side, we've got cervical radiculopathy. This is driven by foraminal compression. Think of those osteophyte complexes literally pinching and exiting nerve root. The clinical signature here? It's pure lower motor neuron dysfunction. We're talking focal weakness, diminished reflexes, and that radiating pain strictly limited to the affected dermatome. But then on the other side, we have cervical myelopathy. This is central canal encroachment, where degenerative narrowing is actually crushing the spinal cord itself. This gives you focal lower motor neuron science right at the level of compression, combined with catastrophic upper motor neuron signs everywhere strictly below the lesion. Taking a look at this T2 sagittal MRI, you can clearly see the cervical disc herniation and just how severe that cord compression really is. When your patient presents with upper motor neuron signs, spasticity, hyperreflexia, or a positive Babinski sign strictly below the lesion, this absolute diagnostic presentation requires emergent imaging. You literally cannot afford to miss this. Those osteophyte complexes are driving these signs, and an MRI is strictly mandated to evaluate that spinal cord crush injury and triage them for emergent surgery. Searing this clinical variance into your diagnostic reasoning is absolutely critical. You have to be able to distinguish these instantly. The mere presence of hyperreflexia or a positive Babinski completely rules out pure radiculopathy. Remember, radiculopathy is just the exiting root, so it's pure focal lower motor neuron deficits. Myelopathy, on the other hand, involves the major cord tracts. It presents with a mixed picture, often accompanied by early gait instability, maybe a Lermit sign, and eventually bowel and bladder dysfunction. If you're seeing those systemic tract signs, radiculopathy's off the table. All right, moving right along to our next section, spinal cord hemisection kinetics. So this syndrome is classically known as Brown-Séquard syndrome. It is strictly driven by penetrating trauma. Classically, we're thinking a knife wound or maybe a shattered bone fragment that cleanly severs exactly one half of the spinal cord. This type of unilateral damage demands incredibly precise anatomical localization. You really need to know exactly which tracts cross where to predict the clinical fallout. This breakdown perfectly illustrates that neuroanatomical map. Let's look at the crossing points. Because both the corticospinal tract, which handles your motor function, and the dorsal columns, which take care of proprioception and vibration, cross way high up at the medulla, severing them down in the spinal cord results in strictly ipsilateral deficits. So you're going to see spastic paralysis and loss of proprioception and vibration on the exact same side below the lesion. It's kind of like simple plumbing, right? The ipsilateral dropouts are mathematically clear. If you cut the pipe after it crosses, the deficit is on the same side as the cut. But here is the great exception to that rule, and it's a super fascinating anatomical quirk, the spinothalamic tract. Because it crosses immediately within the spinal cord at the anterior white commissure, a hemisection actually cuts the fibers that have just crossed over from the other side. Because of this, you absolutely must look for this specific contralateral sensory dropout as your definitive diagnostic anchor. The pathognomonic marker here is a contralateral loss of pain and temperature, starting strictly 1 to 2 levels below the lesion. Next up, we dissect the ischemic cord syndromes, specifically comparing anterior versus central ischemia. Let's break down the mechanisms here. Anterior cord syndrome destroys the anterior 2/3 of the spinal cord. This is classically a watershed infarct driven by occlusion of the anterior spinal artery. We frequently see this following catastrophic events like a thoracic aortic aneurysm repair, and it drives profound bilateral spastic paralysis along with bilateral pain and temperature loss. Now, central cord ischemia, on the other hand, often follows forced hyperextension injuries, especially in elderly patients, or it can come from a central commissure expansion, like a fluid-filled cavity. Now, you absolutely must memorize this rule. We call it the sparing mandate. The definitive diagnostic marker for anterior cord syndrome is the complete preservation of the dorsal columns. See, because the posterior spinal arteries supply the dorsal columns, an anterior spinal artery occlusion spares them entirely. So if your patient has massive bilateral paralysis, but they can perfectly sense the position of their toes, those dorsal columns are perfectly intact, and that isolates the ischemia strictly to the anterior supply. Conversely, let's examine those central cord dynamics, particularly syringomelia. Basically, a central fluid-filled cavity expands outward, and as it does, it severely crushes the crossing spinothalamic fibers right there in the anterior white commissure. This localized destruction drives a highly pathognomonic, quote-unquote, cape-like bilateral loss of pain and temperature sensation, distributed perfectly across the shoulders and neck. Oh, and keep in mind, it's also frequently linked to Arnold-Chiari malformations. The critical variance here between anterior and central cord syndromes comes down to the motor distribution. Anterior cord causes profound bilateral motor deficits everywhere below the lesion. But central cord lesions, they will heavily target the upper extremities, while relatively sparing the lower extremities. Why is that? Well, within the cortical spinal tract, the cervical motor fibers are located medially, meaning closer to the center of the cord, while the sacral and lumbar fibers are positioned much more laterally. So naturally, an expanding central lesion is going to hit those upper extremity fibers first. Okay, let us lock this matrix in with a high-stakes clinical simulation, the master case. All right, here's your patient profile blueprint. We've got a 70-year-old male presenting after a motor vehicle rear-end collision. He's complaining of severe bilateral arm weakness, but interestingly, he is able to move his legs normally and can perfectly sense the position of his toes. But take note of the embedded diagnostic trap here. He sustained a minor head laceration with transient loss of consciousness. This blueprint strongly demands precise localization. That superficial head injury is explicitly deployed to heavily tempt you into a misdiagnosis of intracranial pathology. Don't fall for it. Let's just apply our structural rules instead. And here is your option matrix, simulating actual, highly competitive exam conditions. We have epidural hematoma, anterior spinal artery occlusion, central cord syndrome, Brown-Séquard syndrome, and cervical radiculopathy. We need to analyze these 5 distinct choices by strictly applying the anatomical rules we just established in this explainer. Let's break them down. Let's execute the diagnostic verdict. Choice 1, epidural hematoma, is incorrect. It fails completely because an intracranial bleed just cannot explain isolated bilateral arm weakness while totally sparing the legs. It's a pure distractor. Choice 2, anterior artery occlusion, also incorrect. While it does spare the toes proprioception, it would cause profound bilateral lower extremity paralysis, which our patient clearly lacks. Choice 3, Brown-Séquard, is incorrect because we aren't seeing that classic ipsilateral motor and contralateral sensory split. Choice 5, cervical radiculopathy, is out too. The weakness is severe and bilateral, which defies an isolated lower motor neuron single rote exit. So that leaves choice 4, central cord syndrome, as the absolute only structural match here. Think about it. A rear-end collision in an elderly male strongly implies a hyperextension injury in a spondylotic neck. The central cord ischemia targets those medial cervical motor tracts, causing the upper extremity weakness, while completely sparing the lateral lumbar and sacral tracts, as well as the posterior dorsal columns. Now, this is exactly what high-level absolute clinical integration looks like. If you master these rigorous structural mandates and completely ignore the superficial distractors, your diagnostic precision will be locked in. Every single deficit is mathematically tied to a neuroanatomical tract. When you truly understand the plumbing, the distractors just fall away instantly. So the question I want to leave you with today is this. Now that you understand the rules of the spinal cord, where will the clinical matrix test your structural integration next? Keep studying, stay focused, and I'll catch you in the next explainer.